All right, great. Next, we'll have Dr. Humraz Samra from Indiana University presenting preventing aortic aneurysm initiation and expansion by inducing immune tolerance to aortic-specific antigens embedded in biodegradable polylactide co-glycolide nanoparticles.
Good morning. Thank you for saying the title. I won't belabor that with everybody this morning. I'm Raz Samra. I'd like to thank you all for the opportunity to present our lab's work entitled Preventing Aortic Aneurysm, Initiation and Expansion. Sorry, how does the... there, perfect, thank you. We have no conflicts of interest to disclose. This experiment stems from a central hypothesis that our lab has developed over the years, that aortic aneurysm development and expansion is at least partially driven by immune reactivity to self-elastin. This slide is an extremely brief summary of multiple years of work, but chiefly, circulating elastin degradation products are released from lung tissue after cigarette smoking. As we are all aware, elastin is a major component of the aortic extracellular matrix. AAA patients have been found to have elevated levels of plasma elastin fragments, anti-elastin antibodies, and elevated levels of Th17 pro-inflammatory cells sensitized to these elastin degradation products. We isolated these Th17 cells from AAA patients, healthy patients, and risk factor matched controls with no AAAs. We isolated these Th17 cells and exposed them to elastin degradation products and then performed flow cytometry. We found significantly upregulated expression of CD154, a marker of T cell activation, suggesting there is sensitization to elastin. Compounding this problem is a defect in type 1 regulatory cells in both function and frequency of these cells. This suggests there is a failure to induce tolerance to elastin as well as sensitization to these elastin products. This excess Th17 can secrete further pro-inflammatory cytokines, degrading the elastin in the aortic wall and resulting in AAA formation and growth. Our hypothesis, therefore, is can we induce immune tolerance to these elastin degradation products, and will this prevent AAA expansion? Our experiment seeks to use biodegradable polylactic acid polyethylene glycol biodegraded nanoparticles to induce immune tolerance. The antigen, in our case elastin, as demonstrated by the green diamond, is embedded within the nanoparticle. Previous work has shown that attachments of these antigens to the exterior surface can result in anaphylaxis. Once the antigen is embedded, it is phagocytized by macrophages within the spleen, where they become antigen-presenting cells, which induce immune tolerance to the circulating antigen. These nanoparticles have been used in other disease models. Our colleagues at Northwestern have used these nanoparticles in their analysis of celiac disease and have recently finished a phase 1 clinical trial. The results briefly summarized on the right there. They found that there was a decreased number of gliadin-responsive T cells in the celiac disease model, which is a similar hypothesized immune sensitization pathophysiology. Our experiment, therefore, took 8-week-old C57BL6 male mice, and at 2 weeks prior to AAA induction, they were randomized into retroorbital intravenous injection of elastin degradation product nanoparticles or ovalbumin nanoparticles used as a control. 1 week after this retroorbital injection, all mice were sensitized to elastin degradation products with complete Freud's adjuvant via bilateral flank injections. And 1 week after that, a laparotomy was performed and AAAs were induced using a previously reported topical porcine pancreatic elastase model. After 2 weeks, we then injected elastin degradation products into the ear pinnas of the right ear pinna of these mice, as well as ovalbumin in the left ear pinna. 48 hours after that, ears were harvested for weight comparisons. Flow cytometry was performed to evaluate for TR1 to Th17 ratios. And micro-CT and 3D reconstructions for volume of AAA and surface area of the AAA were assessed. Previously, we had found that mice sensitized to elastin degradation products have elevated levels of inflammation and a decrease in the TR1 to Th17 ratio in both the blood and the periaortic lymph nodes. It's a relative animal model that is homologous to the human condition and allows us to perform these experiments with some accuracy, and we found some very promising early results. As we can see on the right, previously sensitized mice had both increased volumes and surface area of their AAAs. When we measured our micro-CT, when we measured the volume and the surface area using the micro-CT with microfill opacification, we found that our elastin degradation product treated groups had smaller aneurysm sizes of 91.4 millimeters cubed compared to our control group of 221.4 millimeters cubed. We also looked at delayed type hypersensitivity reactions and used it as a cutaneous measure of immune tolerance. On the right, previous work has shown that injection of elastin degradation products in the ear pinna of sensitized mice induces significantly more inflammation as measured by ear weights as compared to controls. However, in our study, we found that elastin degradation product treated mice had similar levels of ear swelling compared to the ovalbumin nanoparticles, suggesting a development of immune tolerance. We further examined the correlation between ear weights and aneurysm size and found that previously sensitized mice had significantly increased ear weights and significantly increased aneurysm volume compared to our controls. This lends support to our hypothesis of an inflammatory response in AAA formation and expansion, and the degree of inflammation correlates to the degree of inflammation in the aorta. So in summary, compared to risk factor matched controls, human AAAs are characterized by TR1 cell dysfunction, decreased TR1 to Th17 ratio, and the activation of Th17 cells to elastin. Incorporating sensitization to elastin into a mouse model of AAA results in larger aneurysms and a decreased TR1 to Th17 ratio, analogous to the human condition, and may provide a better platform to tailor therapeutics for early AAAs. So in conclusion, these are very promising early results for the attenuation of AAA propagation and expansion. We are currently continuing the experiment to increase statistical power as well as evaluating different components of nanoparticles. There is evidence to suggest nanoparticle therapy in modulating the immune response, and it's an exciting avenue for further research. And we hope to use the results of the study to support a US FDA investigational new drug application for a phase 1 clinical trial. Thank you for your time.
Thank you for your great talk. Do you know what size nanoparticles you used for this study?
Off the top of my head, I can't actually recall, but I know we used the nanoparticles that have been developed by Northwestern. Unfortunately, off the top of my head, I can't remember that. I'm sorry.
Okay. No worries. And then the second question is, did you see any complications like thrombosis within the veins after you injected these nanoparticles?
No, not that we've evaluated. We didn't see any other sequelae from thrombosis or any kind of reactivity like that. But again, we're continuing the experiment, so there's a possibility that we might see that in the future.
All right. Thank you. Sure.
Thank you for that talk. You were focused on elastin as a degradation product. Did you evaluate other degradation products such as type 4 collagen that might also have a similar effect?
Yeah, that's actually a really good question. We looked at a lot of different products, particularly type 4 collagen, as you said, and we found that there was no activation of Th17 cells. So it is an area of continued research, but I think the elastin is the main inflammatory response.
Thank you. That was a great talk. I just have a general question for your lab's work. Do you think it's more the pathology of the Th17 cell that's the problem, or the lack of Tregs, right? Because it's always looking at a balance between the two. So I wonder, is it that you have too much IL-17 and Th17 cells, or is it that you have too few Tregs that are the problem? Like, what's the main thing to tackle here?
So what we're thinking is that it's too much Th17 as compared to the lack of TR1. And you mentioned IL-17, which is exactly what we've been analyzing as well. So we're actually continuing to work using anti-inflammatory cytokines like IL-10 to see if injecting those can have a mitigating effect on AAAs as well.
All right.
Thank you.
Thank you.
you.